Well, hello and welcome to the next in the series of the Royal College of Pathologists Guideline Implementation webinars. My name is Peter Johnston and I am the Vice President for Professionalism at the College. I'm delighted to be able to introduce you today to some experts in the field of uveal melanoma and introduce the new data set on histopathological reporting of uveal melanomas. These guidelines were put together by Professor Sarah Coupland from Liverpool and Dr. Luciane from Manchester. And I'm really delighted to have Sarah here today to present to you around the new guidelines. As we go forward, there will be an opportunity for you in this webinar to ask questions. And so I'd be pleased if you would please put your questions in writing on the Q&A tab on Zoom so that we can pick them up. And I will pass the questions on to Sarah as we go. And so without further ado, can we please start with the presentation? And Sarah, delighted to welcome you to do this. Thank you very much.
Thank you very much, Peter, for the kind introduction. It gives me great pleasure to present the update on the data sets for the reporting of uveal melanoma. So I'll just share my slides. So hopefully you can all see these. So I was speaking about uveal melanoma, which is a rare primary intraocular tumor which occurs in adults with approximately 6 to 8 million per million per year in the UK. So that equates to approximately between 6 to 800 in Great Britain. And these melanomas arise in the uveal tract, which comprises the iris, the ciliary body, and the choroid. And the most common of the uveal melanomas are the choroidal melanomas, followed by the ciliary body melanomas and the iris melanomas. And here are examples, histological examples of these tumors. And here is an example of an iris melanoma. Here is an example of a nucleated eye with a ciliary body melanoma, which has abutted the lens, causing its deformation. And here is a typical mushroom-shaped choroidal melanoma with the strangulation caused by Bruch's membrane and this mushroom shape with the apex and the congestion of the blood vessels. So uveal melanomas are distinct from their cutaneous cousins, and they typically metastasize in approximately 50% of patients to the liver. So when we're reporting uveal melanomas, we're also highlighting particular features of these tumors, which reflect the degree with respect to risk of metastasis. So the 2021 guidelines or data set for histopathological reporting of uveal melanomas was drawn up by myself and Luciane Irion. And this was a revision of the guidelines that were put together by myself and Dr. Dreher in 2017. So not a huge amount has changed, but what I'm going to do is I'm going to highlight the changes within the data set. And this is on the basis of the evidence in the literature, and which has provided us with a font of knowledge in terms of genetic changes within the tumors, and also with respect to the updates of the TNM staging system. So this is the introduction of the December 2017 dataset compared to the 2021 dataset. And essentially in it, there's been an increase in the text concerning the genetic mutations and alterations which are of prognostic significance for these patients. So this information regarding the genetic alterations in uveal melanoma has come from large studies, including multi-center collaborative studies. But what I want to sort of highlight here is that, again, that the uveal melanomas are distinctly different from their cutaneous cousins, and that in approximately 80%, you have an initiating mutation in either GNAQ or GNA11, and then to create the malignant tumor, then you have additional mutations and copy number variations, which are listed here. And the most significant ones in terms of prognostication are chromosome 3 and BAP1. So the Cancer Genome Atlas was a study which was published in August 2017, and this information has been fed into the data set of 2021. And essentially, uveal melanomas can be divided into 4 biological subtypes. And this is on the basis of whether on the status of chromosome 3, whether monosomy 3 is present or not, and whether also BAP1 and an inactivating mutation of BAP1 is present. So you can see that subgroups 3 and 4 are characterized by monosomy 3 and BAP1 mutation, whereas subtypes 1 and 2 have a normal chromosome 3 and either an IFAX mutation or an SF3B1 mutation. And as one moves from subtype 1 to subtype 4, there's an increasing risk of metastasis, and typically these metastases occur in the liver. At present, there aren't any effective treatments for metastatic disease. And the TCGA paper, which was published, as I mentioned, in 2017, examined 80 primary uveal melanomas, and you can see these subgroups have clinical significance in terms of outcomes of the patients. So for the laboratories who cannot undertake all of the various genetic examinations of these tumors, in the meantime, a number of studies have demonstrated that immunohistochemical studies using BAP1 provides a surrogate information regarding the status of the BAP1 gene. And so if you have nuclear BAP1 positivity, this usually correlates to a spindle cell melanoma with a low mitotic count, and these tumors usually don't have these matrix patterns, which are called closed connective tissue loops. Whereas high-risk UV melanomas typically are epithelioid celled, high mitotic count, have these connective tissue loops, and have nuclear BAP1 negative. And us and other groups have demonstrated the clinical significance of this BAP1 staining. And as a result of this, BAP1 has been introduced in most laboratories as part of the routine workup of a uveal melanoma. So within the data set, it is recommended that the BAP1 immunohistochemistry is undertaken. So moving to the type of samples that are received in an eye pathology laboratory. So we've expanded this slightly in the 2021 data set to indicate that we not only receive fixed eyes, but we also receive fresh enucleated eyes. And the advantage of the fresh enucleated eyes is obviously that you can do tumor sampling, and this may be for genetic reasons or also for biobanking. So whether the eye comes in fresh or fixed, it's the usual undertaking in terms of the grossing the specimen, getting the orientation of the eye, locating all of the different extraocular muscles and typically the 6 vortex veins. This is a fresh enucleated eye, and obviously also when grossing you describe any particular abnormalities, as in this case you can see that there is a black dot, obviously extraocular melanoma, and also there's a deformation here in the angle, suggesting that probably underlying here is a ciliary body melanoma with extraocular extension. So to highlight that, then you do transillumination, you see a shadow in the area of the tumor, and when we cut open the eye fresh, then we mark that area and then typically do what is called a pupil optic nerve parallel cut. And then this reveals the tumor inside, and these uveal melanomas can be pigmented as shown here or unpigmented. And if you have the consent of the patient for either genetic testing or biobanking, then you can then undertake this sampling and place them in the appropriate tubes. So this first cut is usually undertaken in the fresh eye, but then the eye is placed in formalin, and the second cut is undertaken the following day, so that then there is the PO block with the tumor inside, and then you have the calots, which are embedded completely. So just to make sure that you're examining all components of the tumor, and particularly if excluding any extraocular spread. So I just want to also highlight that we not only receive enucleation specimens, we receive samples which are considerably larger and those that are also considerably smaller. So an orbital exenteration we've been receiving recently as a result of advanced disease, possibly as a result of the delays in presentation caused by the COVID pandemic. But you can have a diffuse melanoma at the back of the eye, in the choroid, with extensive extraocular spread. So when extraocular spread is seen, this has to be described obviously in terms of its size, but also whether it is encapsulated by any soft tissue. If there should the tumor pass into the surgical resection margins of the exenteration, then it's more often not the patient has to have low dose irradiation to the orbit following the orbital exenteration. Increasingly, there are so-called local resections, and these local resections can be iridectomies, where you may have an iris melanoma and only this melanoma is removed from the eye. The eye stays intact in place. And similarly, you can also have local resections of choroidal melanomas. So when we receive such samples, it is important to report the surgical margins, orientate them, whether it's anterior or posterior, and obviously also report whether any tumor cells are passing into the intrascleral surgical margin. More often not, the surgeons do place a ruthenium plaque over the surgical site. However, we are required to report the extent of the tumor cell spread. Also, there is perhaps quite rarely, we do receive endoresections, which is like where the tumor is vacuumed up and tiny little fragments of the tumor are sent in universals and cell blocked, and then the histological workup is the same. However, obviously we cannot report anything to do with resection margins in such specimens. So intraocular biopsies are being undertaken in patients who are going to receive either a ruthenium plaque or proton beam therapy for their choroidal melanoma. And these samples are sent to us in like aspirates, and they can be undertaken either transretinally or transsclerally. What we do in Liverpool is we create a cytospin which is stained with MGG. If we're unclear still that this is a melanoma, then we undertake the immunocytology. If, however, from the morphology it represents a classic melanoma, then we spare the cells and use them for DNA extraction to undertake the molecular studies, which are required for the prognostication in the patients who have consented for that. In some cases, intraocular biopsies are undertaken to exclude the possibility of a metastatic tumor, such as metastatic breast or lung cancer, and these are the most common ones. This is an example of a metastatic breast cancer, and this was stained using A1A3 and also with estrogen receptor. So this is metastatic breast cancer. In the case of metastatic lung cancer, we typically would stain for cytokeratin or TTF1. And if there is any reserve material, we would also extract the DNA to undertake any mutational testing for EGFR or the other mutations which are found in lung cancers. And this is found to be of value for patients who have widespread disease. Returning to the choroidal melanomas, the molecular testing which has been recommended varies, but typically they are examined for copy number variation with concentration on chromosome 3 for the demonstration of disomy 3 or monosomy 3. And there are a number of techniques which are applied more and more through either single Sanger sequencing or next generation sequencing via the genomic laboratory hubs here in the UK. additional mutational testing is being undertaken, and that includes BAP1 and SF3B1 at the moment. So just addressing briefly the TNM staging system. So this has been updated since the December 2017 guidelines. Just to highlight that the iris melanomas have a slightly different TNM staging system to the ciliary body and choroidal uveal melanomas. And so it's important to note this. And more often not, that when reporting an iris melanoma, it's in direct correlation with the clinical findings to report the PT stage. With the ciliary body and choroidal melanomas, here we take into account whether there is whether there's ciliary body involvement, B, whether there's extraocular extension, the size of the extraocular extension, and obviously the size of the tumor within the eye. The N in the TNM staging system is perhaps not as relevant in uveal melanomas because virtually all uveal melanomas metastasize hematogenously, and the M refers typically to the metastases in the liver. This TNM staging system was put together as a result of a collaborative effort by ophthalmologists and ophthalmic oncologists and pathologists in Europe. And through that, there were sufficient numbers to create this matrix, which is still the mainstay for the TNM staging system. And then just finally, an appendix to the 2017 dataset, and which has been slightly modified for the 2021 dataset, is this proforma for reporting the uveal melanomas, which is like a summary, and it takes into account all of the most relevant features and includes the TNM staging system at the bottom. So I think with that, I'd just like to conclude by saying that there are 4 ophthalmic pathology centres in England and 1 based in Glasgow. We are more often not associated with an ocular oncology centre, and so as a result of that, we all of these centres see quite a large number of uveal melanomas and other types of ocular melanoma, and have the other centres mentioned here have been stakeholders in the putting together of these data sets. And with that, thank you very much for your attention, and I'm happy to take questions.
Sarah, thank you very much. As somebody who's much more general and lymphoma driven, that was very educational for me. So thank you very much. I've enjoyed that. We haven't got any questions in yet, so I hope there are lots coming. But in the meantime, one of the things that I found really interesting was thinking about BAP1 immunocytochemistry, really, and that there are parallels there I see with, for example, HER2 testing in breast cancer, and indeed a V600E, I've forgotten the name of it suddenly, in melanomas. BRAF, thank you. So can you tell me what's the relationship between the immunocytochemistry demonstration of whatever it is we're staining, which is presumably a product, and the prognosis or the effectiveness of the relationship between that's what's going on in the genome?
So the immunohistochemistry, the nuclear or positivity or negativity, is like a surrogate for the mutation status of the BAP1 gene, which is located on chromosome 3. It's not 100% concordance. There are nuclear BAP1 positive tumors which still have alterations in the BAP1 gene. However, most studies have shown that there is very, very good correlation. And it is a wee bit unfortunate in that where there are BRAF mutations, for example, in skin melanoma, it's important to report that because then the patient, should they develop metastases with a skin melanoma, they could be eligible for BRAF inhibitors as a form of treatment. Unfortunately, we don't have treatments which can be directed against the BAP1 mutations. So it's not a targetable mutation. And so unfortunately, none of the mutations which are present in uveal melanomas at present are targetable. But that's something that obviously a lot of research is going into, and also looking into immunotherapies, how we can improve the response of metastatic uveal melanoma to these more novel therapies.
Yeah, thank you. And just there's a question in about, which is related really to this. And if you've got a tiny biopsy, which you raise the diagnosis, a differential, is this a nevus or a melanoma? And there's not enough really to stain positively for melan A or BAP1, and you don't have enough for molecular testing. Are there other ways that you can use to ascertain whether we're actually looking at a nevus or a melanoma?
That's a very difficult question. So
I rather thought it would be.
So particularly difficult is when iris biopsies are undertaken, because typically iris melanomas are spindle-celled, and iris melanomas tend to show a lot more indolent clinical behavior compared to the ciliary body or the choroidal melanomas. And so it can be quite tricky saying whether it's an iris nevus or an iris melanoma, and that's definitely where you need the clinico-pathological correlation. But also you may be saved if the ocular surgeon provides you a bit of stroma. So it takes a larger chunk of the iris, and where you can see where the cells are located, whether they're located within the iris stroma or whether they're on the surface of the iris and forming a thick carpet. And if it's the latter, then that would speak for a melanoma. Whereas if it's still within the stroma, then that would speak more for an iris nevus. Turning to an intraocular biopsy where you've got very limited material and there are spindle cells, and you're being asked to make a diagnosis between a choroidal nevus and a choroidal melanoma, you really do need to have the clinical pathological correlation there. If the tumor is less than, for example, 2 millimeters in height, then really it can be quite difficult to say, 100% hand in the fire that it is an iris, that is a nevus versus a melanoma. But there are some features which would point towards a melanoma, that sort of oval nucleus, prominent nucleolus. And yes, if you were able to get sufficient material to do any BAP1 immunocytology, and it was negative in the nucleus and in the presence of a positive control, then that would speak for a melanoma. That would just help you sway the diagnosis, but it can be extremely difficult in some cases.
Yeah, thank you. I guess part of the issue here is the methodology that we use to determine what how we get material tested. And in terms of the molecular pathology, we're looking at a variety of different modalities here. We've got cytology preps with cell blocks, presumably. We've got fresh material if you get a whole enucleation specimen. We've got fixed material, presumably, if it's referred. So what's the preferred method, and is there a good read across between different methods of sampling for molecular pathology in this regard?
So I think probably, as in all tumors, if you were to have a fresh tissue sample, then that is the best. That is the ideal scenario, and you can really do a broader range of analyses, in not only the copy number variations, but you can do a broader mutational analysis. But this, yes, as you say, we are a super-regional referral center, and so we receive fixed eyes. And so we typically use MLPA, which is just looks at the copy number variations of chromosomes 1, 3, 6, and 8. And so we extract DNA from a representative tumor block, which is so if the wet specimen is sent to us in formalin, then we prepare it as I described in the slides. But in some cases, we receive a representative tumor block, and from that we extract the DNA and then perform the MLPA. There is, as you know, also variation in the formalin and the strength of the formalin, and that affects also the DNA quality. And in some cases, we have to ask the referring center to send us, if possible, a blood sample from the patient as a control, and then that helps us undertake the genetic analyses. But if we receive very fixed material, then it does limit the analyses that can be undertaken. But that being said, the next generation sequencing techniques are improving, and they can work with perhaps lower quality DNA, and so that there can be some information fished out of the samples.
Okay, thank you. Just before we go on, I need to ask the participants, please, for some help here. And that I'm a general pathologist, and I do hemepath, and so I really need some informed questions coming in, because I'm going to struggle shortly if you don't come with some more, please. So in the meantime, there is a helpful person out there who has given us one, which is about the best way to assess for a closed vascular loop, with the assertion or the assumption that this is a tricky process, which is time consuming and may be difficult. How would you go and address that question, Sarah?
So the original descriptions of the various vascular patterns or connective tissue patterns that were seen, that are seen in uveal melanomas, was in the 1980s, and that was a group led by Bob Folberg, and they described that the best way to demonstrate the various vascular patterns was using a PAS stain without the counter H&E stain. So what we would recommend, and sorry, then placing it on a green light, I don't think that it is actually required in all cases, and that's certainly something that we don't do. So what we typically do is, first of all, you can more often not see closed connective tissue loops in an H&E. You can get an indication of them. If not, you can do the additional PAS stain, and then they're more often not, they're highlighted.
And so you don't use immunocytochemistry for that?
No.
Okay. I do have to ask the audience, please, can you give us some more questions? One thing that while you're thinking of that, one thing that's puzzled me about the presentation really was the definition of what is extraocular and what is not extraocular. Exactly what does that mean, and why does it matter, I guess, and with a practical connotation thereafter about reporting. So can you perhaps help me with that, Sarah?
Yes, okay. So so when we're reporting uveal melanomas, we're obviously describing the intraocular tumor arising from the uveal tract. But uveal melanomas, they, like all tumors, they are quite sneaky, and they use routes to escape from their limited area where they're growing. And the sclera is very tough. But there are various exit routes that the tumor cells can use, and these they can spread along exiting nerves and blood vessels, and then they can so if you have a choroidal melanoma, a posterior choroidal melanoma, they can pass along the routes, and as I showed in that larger larger specimen, they can pass into the orbital space. And so that's what's considered to be extraocular melanoma. And so it's passed through the sclera. In some cases, particularly very fast-growing uveal melanomas, they can undergo necrosis, and this necrosis can actually lead to the sclera being almost dissolved and the tumor passing into the orbital space. So that's one sort of definition of extraocular melanoma, sort of transscleral spread. But then there are other ways that you can have extraocular melanoma, and that's including infiltration of the vortex veins. So I spoke at the very beginning that there are typically six vortex veins. So they're always examined in a nucleation. And so if you find tumor cells within the one or more of those vortex veins, then that is also by definition extraocular melanoma. And then also I showed that picture of the fresh eye with the anterior black nodule. That is probably a ciliary body melanoma, which has passed into the angle of the eye, into the trabecular meshwork, into Schlemm's canal, and potentially also some of the emissary vessels into the anterior subconjunctival tissue, and then ultimately perforated also the conjunctiva. So this is another example of extraocular melanoma. So it's not yes, I can understand perhaps the confusion by that term, but it is essentially meaning spread of an intraocular melanoma outside the eye into adjacent tissues, directly adjacent tissue, not distant or systemic tissues like the liver.
Yeah, I might come back to the liver later because it's an interesting one. That in the meantime, there's a question here which is a bit more about the detail and again classification of the lesion. So if we have a chromosome 6p gain, disomy 3 and chromosome 8 assessment keeps failing, how then do you decide how you should categorize these patients into higher low risk groups for treatment and follow-up?
Okay, so I mean that's a good question. Just to say that when in Liverpool, when we provide a prognostication score or classification or stratification for the patients, it is not only based on the genetics only. So, and I didn't really have time to go into this, but there is, with the help of clinical statisticians, we have devised a prognostic algorithm which includes a number of factors, which is the age and the gender of the patient, the location of the tumor, the size of the tumor, and the size of the tumor includes the largest basal diameter and the height of the tumor, various histological features, and then the genetics. So they are all incorporated and fed into an algorithm which has been tested internally and externally through multi-center studies. And so an individualized prognostic curve is generated for that particular patient and matched to an age and gender matched population. And that curve is then passed to the clinicians, and they then speak with the patients regarding their individual risk for developing metastases or not, and then also to the medical oncologists who organize the liver surveillance. In the case that was mentioned, disomy 3 alterations in 6p question mark alterations of chromosome 8, that is probably, if it's a small tumor, if it's spindle cell, if it's a low mitotic grade, that is likely to be a low risk uveal melanoma.
Thank you. If I can just come back to the issue about the liver. You know, cutaneous melanomas are notorious for going lymph nodes and everywhere. What is the predilection for the liver, and how does it, presumably it has to be hematogenious spread, but what is the predilection for liver, and is there a biological explanation for that, or is it hypothetical?
So we're definitely still trying to work that out, and this is something that has been noted for years. Actually, there was you'll be interested to know, I think there was a young Scottish surgeon called James Woodrop, I think his name was, who undertook a number of autopsies, and he described this heterotropism of uveal melanomas. And if you want, I can send you the article because he wrote his thesis about it. And but there are a number of thoughts, including the eye is considered to be an immune privileged site, and so too is the liver within the space of Dis. And typically the metastatic uveal melanoma cells spread to or sort of sneak in to the space of Dis, and then they establish over time, the metastatic colonies form. And it's only once they sort of become quite established that there is an immune response. And this is something that we're still trying to work out. Why is it possible for the metastatic uveal melanoma cells to be able to circulate in the bloodstream, almost hide away from the immune system, and then seed the liver, and then form the colony, the various colonies, and then only then is there an immune response. More often than not, that immune response is lymphocytic in terms of CD8 positive cells, but more often than not, they're so-called exhausted cytotoxic suppressor cells, because they don't express granzyme B or some of the cytotoxic markers. So that's one theory, is that there is this immune privileged sort of environment, and then there are suggestions that there are various ligands present in the liver, which enable the metastases to latch onto. Also, there is a suggestion that of the provision of oxygen within the liver. There's a double circulation in the liver, like there is a double circulation in the choroid. And then finally, liver hepatocytes themselves obviously they're quite nutritious, and so can provide potentially the nutrients that are required there. The other site, second most common site, are the lungs. And again, there's probably some arguments as to why they occur there as well.
Okay, thank you very much. Well, I think we're really just running out of time, Sarah, and I think we should probably draw this to a close. Everybody should know that the recording will be made available later on the college website, and that'll include the question and answer sessions. And this will be a resource for members, and we would really welcome any comments you have on this, both in terms of for the college feedback, but also in terms of informing future editions of the guidelines, and any interest that there might be in people helping to compile these as we go ahead. So if you watch out, you'll find this appearing on the website in due course. And so that just leaves me to conclude with a couple of comments. First of all, to thank Sarah Coupland and Luciane Irion, who was unable to be here today, for the work that underpinned the production of the guidelines, and Sarah particularly for presenting it today. I would also like to thank the clinical effectiveness team at the Royal College of Pathologists, Maria Feo, Cynthia Mitri and Gamze Zen, for their considerable work in producing today's event and the series of such webinars, which leads me finally to say our next webinar is on the 29th of September on the implementation of guidelines for reporting soft tissue sarcomas, and we look forward to welcoming you to that. So thank you for coming, and thank you for your participation, and enjoy the rest of your day wherever that might be. And thank you and goodbye.